Yeah, I really so much better than when you're well. It's like I go out saying no. With you have to, because everybody else is on
Well, I was reading my. I don't know. No, I understand that. I may there's a big biology. Well, I'm technically here in the
Yes. Actually, fine right now. Like, I'm not going to tell you no as long as you have the right whoever originally emailed me.
Just for a little bit. Yeah, I got to give a lecture. Well, medical school up here.
And I'm not going to give out her card by accident. That's for my people giving it my card. No, not from
My usual 4 jobs. Worked 2 years
I've got it all right now.
Got robbed.
I think that I'm voting out for like a week.
In March, I'll have to look at certification. I think it's 11 or 12. And I saw the largest American flag I've ever seen.
Any travel? Yeah, China. All right. I brought a bowl of candy. Please help yourself. And if you need more, I can restock that. And I don't know about you, but I'm starving. So there's candy there. So no one can become hypoglycemic. No patients. All right. We're going to go ahead and call order 12:08. Thank everyone for giving a little break there. I know we got a long first meeting before this. Shelley, can we do roll call, please?
Dan Spade.
Here.
Frank Walter.
Here.
Gail Bradley.
Present.
Glennis Seaman. Jason Johnson.
Here.
Jonathan Madam.
Present.
Joshua Gaither.
Here.
Julie Augenstein. Here. Kevin Foster. Michelle Preston. Ryan Page.
Excellent. We have quorum. Thank you. Next up is the attendance report. Just a reminder, if you missed 2 consecutive meetings, you will receive a message from the Bureau inquiring if you would still like to participate in the council. So thank you everyone who is here today. Vacancy, we have 1 vacancy for a physician specializing in cardiac care. If you're interested in participating, please submit an application on the governor's website. And again, this is up to Governor's Board and Commission, so once the application is there, and they go through their process and generally notify us. There is a little bit of lag time once the applications are submitted. We are due for a bylaw review this year. We generally do these every 3 years. The goal will be to review these and start discussion at the May meeting with a vote for approval of any recommended changes at the September meeting. Next up is Bureau report. Terry.
Thank you, Dr. Bradley. In your packet is a table that shows the timeline for the various rule packages that we have ongoing right now. The big takeaway is that the CON rule process won't begin in earnest until probably March or April of this year when we release the first draft language. That language is based on the feedback we've received from the stakeholders in our internal review of the rules. We will advertise it broadly, and we will hold that meeting at a very big place so that everyone who wants to participate can. The next meeting about rules, though, will likely be a joint meeting looking at the equipment and inspections for the air ambulance and the equipment inspections for ground ambulance so that we can harmonize a language that's appropriate between those two, and we'll advertise that. So that's the next one that's going to be forthcoming. And that's all I have.
Thank you. Next, Ben service section. I think most of they're right on time.
Oh, perfect. From my update?
Yes.
Okay. So this will be relatively brief, mostly the ASTR to AZPure's data linkage is almost done. We're doing some testing that will hopefully be done very shortly, and then the HIE linkage is available. If your agency is interested, please let us know, and then we will talk about the other projects we've been working on here very shortly that are the EMS report, the CAF annual report, and Tableau trauma dashboard and tax. Not yet. I don't know yet.
All right. Thank you. Next up is the EVA annual report.
There you go.
Okay, so I just have to describe them, right? We are not going into the details.
Just a brief description. We'll bring it up so people can at least see what it looks like and where to find them.
Basically, there are 4 things. One is EMS annual report, then another is a trauma annual report, and then there is a dashboard, and then there is a cactus data. These are 4 reports we have developed, and EMS annual report, this uses 2018 EMS data, and it talks about basically gives you an overview of the 911 calls and interfacility transports. You know, how many are there? Well, which month it is more? What day of the week it is higher? And again, you know, by age, by county, what is the volume calls by county, by urban and rural areas, this kind of information this report gives. So this report does not talk about specific illness or specific provider primary impressions, but it talks about in general the EMS call volume burden and how it is distributed throughout the state of Arizona. So over here you can see that we have 900,000 EMS incidents reported, and out of those, 678,000 for 911 calls in a year and 48,000 for interfacility transport. And then it goes into detail about explaining those 678,000 911 response. So if we scan fast, we can see that it is this age. You want to go and scan it? Yeah. So it talks about the month and then the day of the week, which day, like Monday and Friday we have higher volume, March is the higher volume, and then, yeah, let's go to the page. Then it talks about the disposition of the patients, what happened to the patient on scene, whether they were treated, transported, refused treatment, and those kind of things. And then the age distribution. Then it goes into the county, which county has a more volume compared to other counties. And then another piece attached to this report is that those patients seen by EMS and those who were transported to the hospital, then what happened to them in the hospital. So what we did is that we linked the data with hospital discharge database, and and then we talk about, what was their disposition, what happened to those patients, how many patients got discharged from the ED, how many were admitted, what is the mortality, and those kind of a thing. And then the last page of this report talks about, goes into the illnesses, like, okay, what are my most frequently seen primary impressions? Well, how much of my call volume is that primary impression? So, for example, if we take cardiac arrest, is that, okay, 7,000 total EMS incidents were cardiac arrest related, and diabetes like 14,000. Trauma was one of the most frequently, like 16% of EMS call volume is injury. So it's 136,000. So that kind of a thing. It just gives you just a picture, or the very upper high level picture, like, okay, what is the prevalence? And then in each of those primary impressions, mortality. So it shows how many people died in each of those categories. Opens up a lot of questions. This is just an overview. This does not answer the questions. It basically raises the question. Okay, I want to go now further dig into this. Okay, what is happening over here? This report, the main purpose is to basically come up with more questions.
So one of the things that when we initially looked at this, the percentages added up to 100%, and then we decided that really what would be more interesting is looking at, if you can scroll around just a little bit, page 18, in that top bar graph there, is looking at types of calls where we kind of suspect that there's more EMS calls, or things that we have an intervention that EMS is doing that could be a significant intervention. So for someone who's seizures, that they could do an AccuCheck, airway management, medicating as needed. So that was why we kind of changed that a little bit. We literally also went through line by line some of the categories that seemed very high and tried to figure out what was high. So what we found was that what was termed neurologic actually included a lot of psychiatric diagnoses, which didn't really make sense. When I saw percent for neurologic that seemed exceedingly high, I said, well, why is that number high? So then we said, okay, let's break that down and look at what categories get you into that. And we realized it was somewhat of just looking at, behavioral emergency is not a neurologic emergency. It's behavioral health, a psychiatric emergency.
Okay. So last time what we did was we defined based on the CMS guidelines, and so it's just depending upon how we want to classify. So based on our requirement, our needs, Dr. Bradley then went through the categories and, separate them out a little bit and modified it so that it basically more the way we want to use it.
So a big thank you to Sri and Vatsal and Ann for all the work that goes into this. This is a huge project, and I think a really nice summary of kind of our EMS system, of what goes on in Arizona in terms of age groups, demographic, types of calls that we're running. There was some discussion about convalescent, so we debated this back and forth quite a bit. To give a little background, that is defined in statute. So we have to essentially, the CON holder has to document a call as a convalescent if it meets specific criteria. So that's why that term, which for me as a physician didn't really seem to make sense, what is a convalescent transport? This is defined in statute. So some of that is trying to meld the data that we see from AZ peers and link that with how it's documented for statute requirements.
Okay. Yeah, so the appendix is attached, which talks about some of the basic some of the common definitions we have used throughout the report. That's a bit about the EMS annual report. Any questions?
Thank you. It looks great. Question. I saw 3 things that related to toxic, or maybe 4. Opioid, substance abuse, suicide, and psych. Is there a way to break out or lump them together in toxicology and then look at them in detail?
Definitely. We can lump the way we want the categories. Right now, we just did it separately because that's how we wanted to just put that information out, But we can definitely combine categories. We can even sparse out more categories out of it and do the analysis the way we want it. Yep.
Thank you. Well done.
Thank you.
So next is Tableau. On Cactus.
Okay. So next is Cactus, and I just wanted to, so that was that process that we discussed it. If you were here for the end of the EMS Council, we spent quite a bit of time discussing Cactus. A big thank you to, again, Vatsal, Ann, and Sri for all their work on this, and Ben as well. This has been a huge undertaking to try to get a good grasp on this Cactus data set. I think everyone in this room is probably familiar. I'll try to drill down about a 20-minute discussion into a couple minutes here. But essentially, the ask last September from EMS Council was that TEPI make a recommendation on a data completion standard to maintain premier EMS agency status, which is a big deal for an agency. When we started looking at the specific data, we recognized that there were some issues with the data and that we wanted to make sure that if a vote was being made on setting a standard, that we were making that decision based on good data. So we went through literally line by line on any data elements that seemed unusually low or off, and we figured out the logic of how does someone get that answer for that question and where do we get those percentages. So we literally went through every line of Cactus where there was an outlier, and then Vatsal had to rerun the data. The data, we're having big IT issues. Literally, she would start it, her computer was non-functional for 3 days, as it just basically spun and slowly ran her data element. That prompted a look into, can we find another way of running the data, new software, hardware, whatever was purchased or used, and that dramatically shortened down that time frame. That then got us to where we are now, which is that we were able to actually run the report and then provide the overall statewide report, and then agencies will also got their own agency-specific report on Sunday. So those all went out. The timeline for Cactus moving forward is now that EMS Council has kind of see where we are and why there's the backlog. That will go to EMSRA, which is EMS Registry Users Group. In February, they will make their recommendation on the data elements to TEPI, and meets in March. And TEPI will review that and make a recommendation on what completion data completion standards should be met to maintain premier EMS agency, and that will go to EMS Council in May to be voted on. So just a little bit of background on this. When I look at the completion report, you know, one of the things that's very quick to realize, some of these elements, the core data elements, we're doing great on. Most of these are 98 to 100%. When you get down to other more disease specifics, our time-sensitive illness and injury, this is really where we have the opportunities to do education. And I think as medical directors, this is where we can really explain to our agencies and to our personnel why it's so important to do the training and on the documentation piece of this. We recognize that most of these things, if you look under trauma center injury criteria, which is line 17, that's probably the lowest one on there. We know that the reason a patient went to a trauma center is usually somewhere in the narrative, but trying to get AMS to understand why we need them to put that in a drop-down field. And the reason being that the trauma centers who have to report data to the trauma database, they actually have to take it from a drop-down field. So, and once people understand that there's an area on their EPCR system to do that, I think they do actually start utilizing that. So I think this can really help guide the education and training in regards to documentation, which ultimately will give us better data to develop QI programs. One of the other outliers we saw was end-tidal CO2. Again, as a medical director, I think that comes up frequently, is if EMS is intubating, is the airway in the right place? If it got dislodged, where did it get dislodged? Was it a transfer from the ambulance gurney to the hospital bed? Was it, quote, never in the airway? This is a question that comes up relatively frequently. So improving documentation and usage of end-tidal CO2 in an area that we can track this as a huge safety data. There's a big national article that came out on NPR, I think about a month ago, from another state regarding pre-hospital end-tidal CO2 use. So these are some of the elements that we could really take forward from this. So that's, again, Cactus, a ton of work went into putting this together. So a big thank you for you guys for doing all the work for this. Any questions on Cactus? All right, next up is Tableau.
I think we have been, I don't want to again go in the detail, right? We just, okay, overview. So Tableau, this dashboard describes the trauma, gives a trauma picture in the state of Arizona. The registry is our Arizona State Trauma Registry we have used, and it's a 2017 data. What you see, and the link is right on our homepage. It does say the trauma Tableau dashboard. And if you see that the way it is designed is that there are 6 tabs, which goes into introduction, talks about methodology, what we have used, what year, how many hospitals, and that kind of stuff. Then it comes to demographics, it talks about how many total trauma cases were submitted to trauma registry in 2017, like 51,000. And then it shows the mechanism of injury, green, or the purple is the age group, and then the gender distribution. The cool thing about this dashboard is that you can now click on any of the we can go back to the introduction. Click on any of the mechanism of injury, and then it's like, let's just click on the struck by against. And it will change the distribution, and you can see, okay, now which struck by against which age group, now it is more of a assault or a category of mechanism. And so you will see it's more of a younger population compared to the elderly, and more male compared to female. So those kind of a things, it changes and gives us the data based on that. Similarly, for each of the tabs, we have either given the county or the mechanism of injury as an option to change the picture, and then the data changes accordingly, so that people can do either mechanism-specific injury prevention efforts or county-specific injury prevention efforts they want to do, and they want to see, okay, what's going on in my county. They can get the data from here and design some kind of intervention program. So that's about it. So we have alcohol, drugs, and trauma mortality information over here.
So this is another amazing piece of work. It was a ton of work to put together this initial report, but then to actually get the tableaus to work with the website. If anyone's trying to meld two different IT systems together, you can realize how challenging that is. So again, a huge project that was accomplished getting this up and available for people to use. So if your agency or a hospital entity wants to look at data specific to you, this is now publicly available. So thank you again to all the work.
Thank you.
And next up is the STAB report.
STAB, and this is not yet available. We just in the morning got approved by the STAB. Will be available pretty soon on our website. So this is still a draft version. The STAB report talks about the whole 1 year of trauma data submitted in trauma registry for the year 2018. And so it gives you an overall picture of trauma in the state of Arizona. And before we submitted data to Arizona State Trauma Registry, so I would say that our trauma registry is a population-based registry now that many hospitals are participating in this registry. I'm not going to go into much detail, but I just want to show the first graph. Okay. So if you see from 2010 to 2018, the trauma rate per 100,000 is increasing. Over the years, we have increase in trauma, and no doubt the number of hospitals are increasing who are submitting to trauma registry. So that also gives rise to this increase, but there is other factors could be also the reasons why there is increase in trauma over the years. Then this also talks about different kinds of mechanism of injury. What is the highest mechanism of injury? What is the mortality in that mechanism of injury? And we know our falls are our #1 mechanism of injury. Like 43% of trauma cases are falls, and then followed by MVD occupants. Then we go into detail about trauma mortality. Then it also talks about the regional differences. It also gives information on alcohol, drug, and what age group, gender, and those kind of things. I mean, there is a lot of information over here. I don't have time to go through this thing, but talk about the traumatic brain injury, the rehab phases there, trauma charges, like in the year 2018, the $2 billion were accounted for trauma charges. So things like that, there is a lot of information. I mean, once it will be on the website, you guys should be able to see the whole report.
I wanted to point out, sorry, quickly, at the bottom of page 18 here, this was quite a bit of discussion at STAB just to kind of make sure that everyone understands for this data element, this does not come from ADPers, so this is data from the trauma centers. So to get on the STAB report, this is patients who end up at a trauma center. That's what creates the STAB report. If you look at the mortality in the state trauma database, which is the bottom left side, versus Dave is the state's mortality death registry, you'll see there's a significant difference. This makes sense because honestly, if you think about a lot of trauma patients, if it's a gunshot wound or there's significant motor vehicle crash, even if EMS performs termination resuscitation or says it's a 901H on scene, that data would never get to the trauma database. So this gives us a little bit better idea of overall mortality.
Hi guys, Kevin Foster.
Thank you, Kevin. In the state of Arizona. So I think this was something that was identified that would be a really useful thing to maybe expand on in the future is can we break down more of that population from days. So I thought this was just an interesting difference of numbers when you look at mortality from trauma in
Yeah,
Arizona?
mortality, we do not capture the hospital deaths. You know, if the patients never come to their hospitals, then it does not get reported to us. So we are basically missing a bigger picture, okay, how many patients have died of trauma, and that's not, basically, we find it from trauma registry will give us a half the information, and you can see over here, literally, the bar size, you know, the difference between the two. When we looked at the death registry, the trauma, there were 3,723 trauma deaths, whereas in trauma registry in 2018, 1,227 deaths were reported. So to capture that in, we had to go to another data source. That's it. Yeah, any questions?
And again, this was just approved at EMS Council today, so this will go up on the website.
That's pretty soon.
Same kind of bulletins. If you go to the main bureau website, you'll see these in that top bulletin of kind of important things that you can just do a quick link to be able to access this information. All right, thank you very much. Next up, standing committee reports for TEPI, Julie.
Nothing new to report there, other than thank you for reviewing the practice data completion report.
Thank you. Next up, Josh, education.
Education Committee met. We welcomed Dr. Amber Rice as the new chair of the group. We approved the formation of a work group to develop a safe sleep training program. That work group, I think, is in the process of meeting. And then finally, we discussed the SMR training that's going to be before us today.
All right, thank you very much. And you're up again for PMD.
PMD, so we discussed several issues that we're going to discuss in detail on the later agenda items, so I'm not going to talk about those. The only thing that's not a current agenda item here is that we discussed the addition of CROFAB and ANAVIP to the interfacility transport list. That item was not added. That agenda item did not pass. And then we also discussed the formatting of new drug profiles, which I think we're going to look at creating and bringing forward to this group in the future.
Thank you very much. And next up, Julia Basis.
Right. At our meeting on November 21st, we were able to finalize the bylaws. We also have almost a full roster. We're just missing one representative from the northern region. We, again, approved the formation of a safe sleep work group with the Education Committee, and then also are working on the Pediatric Emergency Care Coordinator performance measure of EMSC. So we're working on kind of finalizing what that could look like in the state before pushing that out.
Thank you very much. And next for discussion and action items, can I get a motion to discuss, amend, and approve MDC meeting minutes from September 2019?
Motion.
Second.
Thank you. First and second. We'll take a quick minute to review the minutes. Any recommended amendments to the minutes? All those in favor?
Aye.
Any opposed? All right, thank you very much. Those are approved. Next, can I get a motion to discuss, amend, and approve the draft education approved updates to the spinal motion restriction training? Thank you, Dr. Beadham. Can I get a second?
Second.
Thank you, Dr. Walter. All right. So this, just to give a little bit of background, we had a very busy MDC agenda the last time around. So this was actually updated probably almost coming up in a year ago now, but because of the fact that we've had some busy MDC meetings, we did not get to this. The Education Committee had made an update to the SMR training curriculum based on the updated position statement that was published in the fall of 2018, I believe is when that came out. So based on that new position statement, we did put together the new training program, and that was approved, but we just did not get to it before. So we need to make sure that this group looks at this, feels comfortable with it, and if we approve this, and this will get posted to the website to replace the current version that's on there under the Education tab. So I don't know if people have had a chance to review this, if people would like to go through it. Slide by slide, I can tell you it was very well vetted, both the first time and the second time around.
Motion to approve.
Dr. Bradley?
Yes.
On slide, I think 65, I think there's a spelling error.
What page is that on, do you know by any chance? If not, we'll find it, but if you just say the slide and the word, we can track that down.
Yeah, I think it's slide 65, or
the package should be page 65.
The package we have, the job that's not numbered the same, because we got two per page. So we can scroll quickly to slide 65, maybe on the,
Divided by 2 is 30.
oh, in the back.
By 30.
Before slides.
It's right before the end.
What's the subject?
Talks about the mental axial instability.
Gotcha, thank you. That's page 29.
Thank you. And what was the,
There's an H missing.
Yeah,
On wit.
the wit is spelled wit, which is cool and hip for the kids, but wrong for education.
Can you collect that?
thank you.
Oh,
The red.
oh, yeah, gotcha.
Great pickup, thank you. So I've got that written down here, so we will make that.
It's red right over.
Any other recommended changes? All those in favor of approving?
Aye.
Any opposed? Thank you very much. Again, these are available on the Bureau's website for download and training purposes. I have used this to teach several different training conferences, and I find it's really helpful to use something that's kind of produced from the Bureau. People really appreciate that, especially some of the more rural parts of Arizona. So please utilize any of the educational documents that we have up there. It's a great resource for people who may be looking to do CEs and not have the time to put together their own training curriculum for that. So thank you for everyone's work on that. Next item, can I get a motion to discuss amended approved PMD's proposed change to Table 1, EMC drug box midazolam?
Motion.
All right, is there a second?
Second.
All right, I've got a first and a second. Josh, that is,
Oh, you want me to talk about it?
sure, I did.
I don't know how my name got on there, but I'll talk
I don't
about
know.
it. So, originally, I believe this was, the change is to change the minimum requirement from 20 to 10. This was brought back to PMD as an issue because, several agencies did not have that much for said, available. So, that's how it got there.
So I think a little bit of background, we had increased the midazolam dose to 20 to kind of match some ramp part if you needed to give a second dose. What came up from a number of agencies is that they carried midazolam and lorazepam, and so if they were carrying both agents, they were then having to carry a very large quantity of benzodiazepines. So with a large quantity of controlled substances, they felt like they were never going to give that many of both agents. So because of the fact the way it is in the drug table, even though it's an or, if you carry both, you have to have a minimum category of 4. Also, the feedback from agencies was that they had a controlled substance drug box locked in their regular drug box, and they physically could not fit the additional extra doses out there. So not only were they not using it, but they couldn't find a way to fit it in a locked controlled setting. The request was basically to take it down to a minimum. As an agency, if you only carry one, you can certainly always carry more than the drug box minimum. But the agencies, the feedback we got from agencies was that this was actually almost impossible to implement.
So this is one of the rare, it's so rare for us to get to talk about something that we actually have pre-hospital data on that's really good. I don't know if everybody knows, but the Rampart study won the National Clinical Trial of the Year award, not in emergency care or neuro, but across all clinical trials in all of healthcare in the entire country that year. So it's a game changer. It's exceptionally well done. Thanks to is Glendale still here? Glendale Fire. They were Arizona's part of it. And Garth, thank you. If Garth hadn't supported that, we never would have been able to do a randomized study like that. But a couple of things. The really key findings, other than actually it wasn't even set up to find superiority, but it did with using IM versus IV, which really probably had nothing to do with midazolam versus lorazepam, right? It probably had to do with what was the striking finding was on average approximately 5 minutes earlier the actual dose was on board when you just gave IM. But there's no reason in the world, essentially all of the follow-up in the receiving facilities was a lines in and you use lorazepam, right? Nobody was continuing IM or for that matter even IV midazolam. So it's perfectly reasonable to have the idea that the emergency dose is a super quick IM dose, and then you're obviously trying to get a line in because it's a sick patient. By definition, they've been seizing for 5 minutes and they're still seizing, at least the time when you give it. So having the plan as we'll get a line in, in the next 5 to 10 minutes when it becomes relevant for a potential second dose. So that actually makes perfect sense. The only kind of asterisk that hopefully that the providers and the medical directors will have, the nuance is, of course, if all you carry is one IM dose of midazolam and nothing else, you may end up with a patient who's been seizing for 15 or 20 minutes now total that you have nothing else meaningful to give en route. We don't typically link drugs, right? We don't typically say, like, if you're just going to have one dose of midazolam, potentially 10 milligrams of midazolam, then you need to have at least something of the other. We don't get that complex with this, do we? And that probably is too complex. I would just make sure that we know that, because the old days where status epilepticus was defined after 30 minutes of continuous seizing, what we know now is at minute 5, neurons start to die. So status epilepticus, that was the other thing that Rampart showed, was defining status epilepticus of 5 minutes of seizure continuously or 2 seizures within 5 minutes without waking up in between. Lots of us think that's, well, it's just a seizure. It's really remarkable that that definition is important. So the idea of, well, our backup is we'll get to the hospital and if they're still seizing, they'll be able to treat the patient is not a good one. So we need to at least educate to that if we make this change, because I understand the change. It makes sense, but that's an important nuance. The person who's at the highest risk is the one who's still seizing 6 minutes after you gave them midazolam and they have good blood pressure and you're ready to give the next dose, and if you have nothing to give, that's not a good thing.
And that was, it had been 10, I think, for years, and because of Rampart, we increased it to 20.
Yep.
But because of the linkage in the drug table of an or, that's what created that issue.
Yeah, 10 by itself is not a good plan. And probably the places that might even make the strongest argument, rural areas and so forth, might be the farthest away from the second dose, right, from the hospital and so forth. And the second dose being the hospital is a really bad plan because we know how fast neurons die now when they're seizing.
And I think that's going to be up to the medical director to educate, because like what we do is for the agencies that are close to us, they always have a rescue and an engine comes. They have 2 drug boxes. So I don't worry about them, so I wouldn't care about that. But my ones that transport an hour to an hour and a half, regardless of this, I'm still going to require them to carry at least 20. So, but again, I think what kind of goes to what you're saying is that's going to be an education for the crews, but also for the other medical directors who aren't here to realize.
I would suspect out of the 100+ EMS medical directors in the state of Arizona, a handful of them know the Rampart study well enough to comprehend the idea of, oh yeah, that's no problem, give the IM, that's what, you know what I mean? So I think, I don't know if we have a special way. I know, Terry, did you ever find the medical directors, by the way? You went looking, right? Is there a way to, at least who we have and whose email, it would make sense to send the information to make sure they're applying that at the local level?
So that is something that I have been working on, is putting together a database as best as I can of the medical directors. So
this would be a great communication from
I
you.
think this is something, we have different silos of lists of medical directors within the agency, so we've been coordinating that and putting together a Google group for the medical directors. You did get a link, I can resend. But that is, the goal is specific to kind of medical direction topics like this. So if we can get a copy of the Rampart article electronically, I can push that out to the group and say, if we do approve this change, we just want to make sure medical directors understand kind of potential ramifications of that change?
The simple way to say it would be make sure you have at least 2 doses of benzodiazepine for status epilepticus, for seizures. That would be kind of to me, that'd be the bullet. So 2 midazolams is fine, or 1 midazolam plus for an IV dose, but something like that would be the way to send it out. And like I say, you think about how much we've argued over the years about things we really don't know about. This one we really do know about.
That was my thought too, just looking at this, and remember in the previous discussions, that was kind of a step backwards to accommodate the realities of reality. But as the Medical Direction Commission, we're directing folks, so I think we need to give them good advice if we're going to take this back to 10, because patients' lives depend on their brains. And just to paraphrase Dan, obviously the data speaks for itself. There's no faster way to kill a brain than make it maximally active and hypoxic at the very least during the seizure.
Brian Beard has that list. He just created one.
Pardon?
Brian Beard just created that list.
Yes, so he has a list of some. So the issue that we have is that, and that was kind of like one of the things we recognize. So Brian has a list of like the base hospital medical directors, but there's a lot of people doing medical direction that aren't base hospital based.
Yeah.
And they may be the ones making a decision. So when we go to only a base hospital list, that's one of the things we've identified. We get a fraction of our actual medical directors in Arizona. So that's one of the things we've been trying to figure out is going to like different groups like ADNMSP saying, can we utilize your group of physicians' names? With the Google group, it's going out as they opt in, so I'm not adding people immediately to it. People have to actually enroll, like I send them a link and they choose to enroll or not enroll. But that is one of the things we're trying, because we do have that group, which is a great starting point, but then we have other lists to add in.
I do have one other concern as we talked about this. To the extent that somebody is still seizing at 6 minutes and needs a second dose, and I don't think the right answer is IV lorazepam. It's going to be hard to start an IV at that time. So I have concerns about this.
Well, I agree, me, when we have something like this where we actually know, I agree. But what is interesting is, this was Arizona data. It's 20 years old, but there's no reason to think people are not as good as IVs as they were 20 years ago. Interestingly enough, across rural and urban settings, the ability to get IVs in across over 300 patients that we did in field observation. This was where the Arizona model of time interval model came. The DHS actually funded this. Interestingly enough, we found in over 200 IV attempts, the pre-hospital success rate for IVs there was 1 patient out of 200 that didn't get an IV successfully. And we had a person, some of you were in kindergarten, but some of you who were, we actually had stopwatch on it. And interestingly enough, the median time in rural and urban areas, no different. Median time from the time that they opened up the catheter until there was, until the success, the median time was 2 minutes, and the 90th percentile time was 4 minutes. So I agree with your concern, but we actually have pretty good data that if you give the IM dose, the likelihood that they will successfully, before the next decision comes up, have an IV in, probably is fairly strong.
What were the conditions, Dan?
It was all over. It was trauma, it was non-trauma, it was all over the state. It was 20 different agencies, rural, urban. It included the national park. I mean, it was all over Arizona.
And it was probably before we were doing IOs 15.
Well, that's true, yeah.
So, I mean, that's
absolutely, that's a good
point.
It was before we were doing IOs.
So, I mean, that's really the fallback, if you're going to do an educational solution to this, would say, you got to do an IO. It's just going to be really,
The thing I like about this as proposed is really that it allows flexibility. We're a very diverse state. So if I'm a medical director who oversees national park paramedics providing medical care in the boonies, and I decide I want to give them Ativan, a longer acting benzo, now they can carry a little Ativan and a little Versed to get to that total. It allows me to have that flexibility, whereas I see the point of the groups that were advocating for this on the PMD side, which is that's a lot of drug to mandate that they carry if they have both for operational reasons. So I think you can give the first dose IM, you can pretty easily get that IV within 5 to 10 minutes. That's a reasonable expectation, and give that second dose of lorazepam. So I'm very comfortable supporting this with the idea that there's a little education that hopefully we can all support moving forward.
I'm comfortable too. Hopefully the education's been there, but.
Yeah. And I think, you know, just a reminder, this was in place before, so when we made the change, it was one of those things that we didn't really anticipate the change from an agency level of, as medical directors, we're like, science is good behind this, let's make the change, and it is good, but the feedback from the agencies in Maricopa County, they said, our transport times are so short for the most part, we wouldn't even get to a second dose of medication. And so that was part of their.
That assumption I wouldn't make.
Yeah.
That's why, like I say, I think I would tell the medical directors, you figure out how you want to do it, but make sure you have 2 doses of benzos, because this is one of about 4 or 5 categories of patients. We've actually proven that what happens in the field actually changes survival, which is rare in EMS.
Well, I think their point of the duration was to be able to get through 10 milligrams of Versed plus a beta Ativan. That would be a lot of, like, if they just weren't going to get through that much on a single call.
Yeah, but one more thing that really astounded me, because we think of, oh, another seizure call. In the patients who got entered, which means they were still seizing basically when EMS showed up, because essentially that's always they've been seizing for 5 minutes at least. You ready for this? Almost 1 in 5 patients died. So status epilepticus is unusual, but it really kills a lot of people. In fact, one of the epidemiology papers estimated that around 10,000 seizure patients die from status epilepticus a year. I mean, you're starting to get up in ranges of auto crash death rates and so forth. So it's really a big deal.
And that was, again, kind of pointing back to Cactus, why we did pull up that data, or not the Cactus, why the EMS annual report, we looked specifically seizure, because it is something that EMS can affect. We wanted to make sure we looked at that data element specifically, as opposed to just all neurologic. All right, I think that's probably enough discussion on the topic. Can we get anyone in favor of decreasing the midazolam to 20 down to 10? All those in favor say aye. Pardon?
With the caveat?
Yes, and sorry, we needed just a friendly amendment, a friendly amendment that you will send out education with the recommendation that you carry at least 2 doses of asbestos. So I saw 1, 2, 3, 4, 5, 6, 7, okay. Any opposed? All right, that motion passes, thank you. Next one was discuss, amend, and approve proposed changes to Table 1, EMCP drug box calcium gluconate. Can I get a motion?
Motion.
Thank you. A second? Second for Jason. So this was another one of those changes that we made and then went out to the agencies, and the agency said, can we please take the 3 grams of calcium gluconate back down to 2 grams of calcium? So that was taken back to PMD. PMD voted to take that back to 2 grams. I think part of this was, again, this is an or, so you can carry 1 gram of calcium chloride, or we had increased calcium gluconate to 2 grams, so this would be saying just taking it back down to 2 grams. And it's been so long now, I'm trying to recall the whole, we were supposed to have done this
Space
for
issue.
Space
It's space in the drug box. It's the same size as the calcium chloride. Now you have to have 3 of them instead of 1. This is a real issue for at least the agencies I work with. We're about to run out of calcium chloride. There's a national shortage. And this addresses those time periods of national shortage. And it purely was a space issue.
Yeah, and I think the reason that we had it as 3 is because, as we all know, 3 of the gluconate equals 1 of the chloride. As long as people understand they're not given the equivalent dose. Here we might be dealing with renal failure patients with hyper K, et cetera. So it may make a significant difference.
Yeah, I actually don't know. I didn't look it up. Maybe some of you know if there's any literature to suggest that 3 versus 2 amps of calcium gluconate really make a difference. I think the literature
There certainly would be no EMS literature, and that's just not going to get randomized.
Yeah, the literature on the hospital side, we only give 1 amp of calcium gluconate most of the time anyways, because calcium chloride is so vasotoxic. So when I treat hyper K in the hospital, I give 1 amp.
I usually get 3.
Yeah.
Just because it's a 3-to-1 ratio. I don't have any data though.
Yeah, I don't either. Practice stuff.
Same.
Any further discussion on this?
How expensive is it? Anybody know?
I don't think it's a cost issue. That was.
Because some of these things are actually dirt cheap. So to me, the question is, do you have it or do you not have it? Is it another space issue? Is it really costly? I assume that its shelf life is not 4 months, right? I mean, so I don't know if it's a big issue or not.
They're relatively cheap
Yeah, it costs $10 to $30
compared to some of the other things.
The Amazon price or eBay?
What's the push on this?
Well, so most of us, as you know, operationally, we have a drug box. It's a physical box, and we have 1 amp in the little area. Now you have to put 3 in there, and they don't fit. So you got to buy a whole new box. And if there's no science to back up the need to have 3, it's hard to mandate a budget expense for that.
I think this is also one of those drugs that's just not used a ton by EMS. So it's one of those things where we actually, with the new TTDGs, we did add in specific education on hyperkalemia, really with kind of an actual picture. Thank you, Ben, for getting the $25 to put the EKG changes for hyperkalemia in there, because it's just something EMS is not trained on historically, of recognizing signs of hyperkalemia where given that calcium is not needed. But I think that's one of the things in the past we just rarely see it given. So that was part of the push, is it's not given very often, and if you're exchanging a 1-for-1.
Do we have the data on how often the drug's given? The state data?
Yes, we can.
On our website.
It's not, yeah, so it would have been from 20.
Whenever?
Yeah, 2016, I mean, last couple of years.
Is this addressed in the education too, that 3 amps of gluconate equals 1 of chloride? Or can we include that?
I don't think it's there. I don't remember. I mean,
The guideline dose is different. So basically it was 1 gram of calcium chloride, and I think we changed it to 2 grams in the treatment guidelines for calcium chloride. Treatment
Guidelines are 2.
I would just, the problem, the reason why this is a bummer is it's kind of like anaphylaxis. To see true dying, impending death anaphylaxis is very unusual, but in the rare event that you actually have it, you really want to be able to treat it. And this is kind of one of those things of you show up at the dialysis center, right, or whatever. It's just, it is really impressive to see in hyper K when you give the calcium and watch the tracing. I don't know if anybody's seen this, but watching a wide complex go like this is astonishing to see. So it's based upon face belief, not really good clinical science, but it's incredibly rare and it matters, but the difference between having 2 or 3 or whatever is probably minuscule.
So in 2017, next year's being cut, so it looks like we gave 299 units of, no, that can't be right. Hang on. 108 of calcium chloride and 21 of calcium gluconate.
So I wouldn't call that exceptionally rare. That's kind of surprising.
I mean, just the difference, and again, everybody knows, it's a 3-to-1 ratio. There's 4.6 million equivalents of calcium and a half of calcium gluconate, because gluconate's a lot bigger than chloride, and there's 13.6 million equivalents of calcium and a amp of calcium chloride. Just because chloride's a lot smaller, and they each have a gram each. So it's just a simple amount of difference.
And you don't have what those were used for, do you?
Sorry?
You don't have why those were used, right?
No,
My assumption is in cardiac arrest primarily, not for
And that can
hypertension.
also be, those can also be interfacility. So these are not, so this is not just 911 calls, so this is also, so this would also include interfacility treatment. So if someone was in interfacility unit where they knew that they
Yeah,
could
now
present
there you would
hypertension.
expect they could be given
So that
extra.
is correct of
Right.
the data.
That's a very good
Put
point.
it in a breast pocket.
and I'm assuming there was a shortage at some point of one of them because it just jumped dramatically in 2015. And it looks like calcium chloride goes from, or I'm sorry, calcium gluconate goes from 40, 43, 53, 99.
That may have been a trend in the preferences.
It's been on the shortage list.
Yeah, well, it's probably both.
And in the Nasemso, I think part of the TTGs, we went to the Nasemso and they specifically had calcium chloride 1 gram, gluconate 2 grams. So in the Nasemso version, that was that change.
Yeah, I don't have a problem supporting the change, especially if we're going to be using that on our DTGs. That's not a problem. Until we find evidence supporting otherwise, to switch to 2.
Especially since it's on the national guidelines.
I'll be willing to bet that more calcium gets given just because of rolling out the new T3Gs.
Oh, yeah.
I think it's a big education piece of when you start talking about hyperkalemia, the EMS, it's just not part of their routine training. All right. Any further discussion on that? All right. All those in favor of decreasing the calcium gluconate minimum quantity from 3 grams to 2 grams, say aye.
Okay.
Aye. From 3 to 2, oh, sorry.
Yeah, can we include just that education piece?
On the 3 to 1, yes.
Yeah, okay. Support it.
Aye. Any,
Yeah.
okay. Any opposed? All right, thank you. All right. Next action item, can I get a motion to discuss, amend, and approve PMD's proposed changes to Table 3, agents eligible for administration monitoring during interfacility transport to add pantoprazole. Josh, your name would assign to this one as well.
I have no idea why, but.
No good deed will go
I
unpunished.
make a motion, Josh can talk.
Second. All in favor? Sorry.
So for pantoprazole, this is a pure issue of continuing the PPI drip for an interfacility transport for a GI bleed. The discussion centered around reducing the need for a nurse truck for this transport. The side effects were considered, this was felt to have minimal to no adverse events associated with infusion and monitoring. And therefore, the PMD group supported that to add to the interfacility transport list.
I'm good with that.
There was
Just support it.
a lot of discussion just in terms of, is it really medically necessary to transport the patient on it? The feeling from PMD was no. The issue is that the sending facility physician would not discontinue that, and so by definition, then that would kind of fall back on getting a nurse vehicle car to transport, so more of a helping to expedite getting that patient to definitive care as opposed to medical necessity, so. Any further discussion on this? All right, all those in favor?
Aye.
Any opposed? All right, that motion passes, thank you. Next motion, discuss, can I get a motion to discuss, amend, and approve updates to ketamine drug profile?
Motion.
All right, can I get a second? Thanks, Julie, for the second. Dr. Gamer, you're up.
Well, I didn't even realize I was up or on the agenda until I picked one up, flipped it over. I don't have anything prepared, but I think the point may be moot because when this first got on PMD agenda back a month ago, we were doing the T3G update, and the SEMSO guidelines talk about ketamine given to pediatric age group. And so with everything being on the table, it was felt that if we wanted to go forward with that, then we'd bring it to PMD and MDC to get input on a changed drug profile that would bring into play the possibility of giving ketamine to the sub-15 age group. But we never went that way. So, and then furthermore, I was under the impression that all the drug profiles are being looked at the Bureau to put them in the new format. So I don't know if there's anything related to SIDE today, and I don't even know if this particular item should be tabled or just taken off the agenda and brought back when the retooled drug profiles are ready. And what would be your thoughts on that?
So I think this got to, there was a concern when we first started the TTTG rewrite a year ago that would we be updating the treatment guidelines with indication that didn't match the drug profile for the state. The decision was made to move forward with the updating the treatment guidelines to match the SEMSO, and so to follow the SEMSO's guidance on those, which is kind of why we ended up doing that. The drug profile project will start, it'll be a several-month project. At the end of the day, the drug profiles are really a guidance. Any individual medical director, once a drug is on the table, can decide indications, dosing, and route for administration. So the pressing need for it is probably not there, but I think there was a concern about us having conflicting documents. And that was why it was put on the agenda initially, but due to the heavy volume of the last agenda, it just got tabled, I think, 2 meetings now, so.
For what I said about the SEMSO not having a pediatric age range, they didn't even have a minimum, but kind of to tee it up with what we felt were at-risk patient populations to omit for treat and refer, they just put 4 years in there. I didn't think we'd want to go in a patient younger than that. And then, like I said, the rest is kind of unchanged in the most recent publication of the T3Gs. So I think the point is moved to act on what's in your packet right at this point, and just bring this back at a later time.
Yeah, I mean, clearly there shouldn't be contradictory numbers, ideas, approach, or whatever. And it's way better to work that out at the committee level than at these meetings in general, right? I mean, there's certainly not an emergency. Except just a reminder that, surprise, 6 years ago we showed up at NAMSP and, some medical director from somewhere had done 43 cases and everything was perfect and there were no complications and nobody ever had any problems. And now that, the pendulum swung, oops, wow, the literature's starting to show sometimes you have significant complications and so forth. So just it's a good time to remember that this relatively new drug in numerous settings will have complications that we do not expect yet, especially because any given provider is not going to get it formulated, those kind of things. But.
And wait for the big new physician statement that's coming out nationally, because it's quite interesting.
A motion to table.
All right. All right, we will, all in favor of tabling the motion?
Aye.
All right, thank you. Next, can we get a motion to discuss and approve removal of oral tracheal intubation, STR for EMT and AEMT?
Motion.
Second.
All right, thank you. So this got added to the agenda, and again, the last time around. This, I think, Jason, you were the one who identified, as we were going through some other aspects and looking at things like entitled CO2 monitoring and other things, Jason brought up the fact that it is an STR for EMTs and AEMTs to perform endotracheal intubation. And so, as an STR, we currently are not able to update rules, but since it was on the agenda, we thought it would be a good starting point to at least make a recommendation from this committee, vote one way or the other to move forward so that when we do get to open that rule and make any potential change to the scope of process, that decision is already in place. But again, we can't change scope right now regarding STR, but I think this group can certainly weigh in and make a recommendation. So when we do get to that process, it's one step that's essentially that are not done. So that is a little bit of just to clarify that we cannot make the change now, but we can certainly make a recommendation from this group. Is there a motion to, we got the motion to discuss it? Any discussion on this piece?
So I want to make sure that I really understand. You mean we're actually removing an advanced procedure from basics in Arizona? The reason why I bring this up is for those of us, Garth and me, I voted against adding it when you actually were in kindergarten out there. Just because all of the issues, it's going to be in the very places you argue that you need it because there's nobody else around, is the place where you're most likely to kill somebody with the procedure because you only do it twice a decade. So I don't think this ever should have been there. And now, as you know, it is a pendulum, but I think it's a pendulum moving back towards center, where we're all aware, surprised, when you don't do a psychomotor skill really frequently, you're not very good at it. And then you add on top of that in these kind of settings, our epi level is higher than the patient's. We are nervous. It happens in the rain, in ditches, at night, in the field. All of those things together make perfect sense to me for us to not have that as a...
And I think most of us have changed over where if we have EMT only rigs, that they're just using supraglottic airways.
Yes.
Yeah.
Almost exclusively.
I think this dates back to the esophageal obturator airway. It was the only other adjunct that was out there. Or it was endotracheal tube, esophageal obturator airway, and then prayer.
And
now we've got better alternatives for it.
And that's right. But my argument at that point is I feel way better allowing a person to die that there's nothing we can do about than killing somebody with my procedure. And we have lots of information that rare intubators do a lot of really bad damage with intubation. So I think we are also perhaps making some assumptions about the rare extraglottic, supraglottic usage, that it's like kind of automatic and you just put it in and anybody could do it. But it's certainly way better than endotracheal intubation as a plan.
Right. And that's why I brought it up, is because I had an EMT who brought it up to me and said, hey, can we start doing this? And I said, absolutely not. Thank you. And in fact, I'm going to bring this up at the state level.
So again, yes, Brian?
I just have one question. There's a number of items that are sitting to go onto the scope of practice model right now, like, you know, the epinephrine IM kits for EMTs, and I think there's a couple of other things. So when you go to try to open that rule, is it your intent to work on the things that have come up, or are you just going to hold off until there can be work groups that can look at the 2019 National Scope of Practice model? So part of it might be important on what your timing is on opening up that table.
We have verbal approval to open. The timing is not, we're not sure about the time. It might be that it would be appropriate for us to wait a little while if the National Scope of Practice is being updated. But I don't know that I control that decision. I'll kind of lean on you guys to advise us on that.
No, it's done. It's done and published, so we can take that and utilize that if we wanted to do a work group like we did back in 2009 to redo that.
The rule process requires an open set of meetings to analyze whatever it is we're trying to do. So we just don't go to GERT.
So this is kind of a rare inflection point. I don't remember a lot of times deliberating on something that I suspect this group will be unanimous or near unanimous on, is an actual safety issue. And here we're not arguing about dosing or I prefer this. We believe this is actually a real safety issue, and we believe there's now overwhelming evidence about this issue. So can you explain the rule obstacle to taking actual action at this point? And then secondly, even in the absence of that, there's nothing wrong with this group recommending to the director that that the director be alerted or something like that, right?
The NBC's recommendations through the voting process will be a very strong signal to the director.
Okay.
So
Regardless of the timing.
Yes, so that's why I wanted to just clarify. I don't want people to think that if we vote this, then it's on, but just, I think it's an important enough topic that I was not aware until Jason brought this forward, that this was available. So I think it was a great thing to pick up. That EMT did himself no favors for identifying a safety issue across the stage, but I think it's a very good process to at least discuss and bring about. Any further discussion that anyone wants to have on that? All right, all those in favor of removing oral tracheal intubation as an STR for EMTs and AMTs, say aye.
Aye.
Any opposed? All right, that motion passes. Thank you.
Can I ask a question? I'm a little concerned we may not have understood the implications for a couple of parts of the state for the AMT. One particular part of the state. There's one part of the state that uses AEMT quite heavily, rural, but have pretty significant medical control.
So most of the intubate, has their medical director approved them to intubate?
I don't know the answer to that.
And most of it goes back to the frequency of utilization. So if how many AMTs do we have in the state anyway?
In that one area, it's not an insignificant number.
Well, I know they have a higher percentage, right? So if it's a group that is intubating frequently, then it might not be unreasonable if that's what they're using.
I just don't know. It may be absolutely appropriate. I don't have. It's the northwest corner of the state, the Colorado City area.
So we're only discussing removing it from the EMT column, not the AEMT column.
We mentioned EMT, but it's written also AEMT. Yeah. It's
So-
in the.
I'm not proposing that. I'm just saying that I want to make sure that
I think, but to Dan's point, I think, yes, it does have implications, but I think, again, getting to the frequency of how often they're actually performing the skills with the other options for supraglottic airways, I think, compared to 4 years ago or 8 years ago, the supraglottic devices, it's become the standard of care in the anesthesia world. They use supraglottic airways for the majority of surgical procedures these days, which was shocking to me. They're not doing intubation nearly as much as they used to, and that was their bread and butter. So I think to get the anesthesia world, they're using IGELs.
Yeah.
So I think if the
That might be an
airways,
education point too. Hey, on one hand, give it, as one take away. There are better extraglottic devices, and really the only contraindication for an extraglottic or supraglottic device would be airway burns or upper airway trauma.
Right. In my kit, I carry an IGEL and a right kit. I don't do anything in between.
Right.
But if we get feedback from somebody, I'd certainly be willing to discuss it again right now.
And Heather Miller as the coordinator, it would be easy to talk to her about. Heather Miller is the pre-hospital coordinator for that base hospital that gives medical direction to where you're talking about. It'd be easy to talk to her to see if they're allowing them to do that or whether they're only using because it's a regular scope of practice at the AMT for all the supraglottics.
Yeah, if they want to put it back on the agenda for PMP, have them come down and talk about what their practice is, what their quality assurance is, how many times they've done it, and then compel PMP to make a decision about putting AEMTs back on.
And we just got feedback on the calcium gluconate and the midazolam and responded. Yeah, it's not that we're unresponsive, but we are the direction commission.
good point.
First, you know how.
Yeah, right. It is the committee's prerogative.
Not in an arbitrary way.
I think, a great discussion. I think the news article and the state medical director for the state involved in that NPR article talked about that the NAMC Medical Direction Commission, so the national, all the state medical directors getting together, his perspective of going to a very public news articles, state hearings, different things in the legislature regarding specifics of what they call in that state cardiac EMTs, which is essentially an AEMT intubating, success rate, use or lack of use of end-tidal CO2, and significant effects of that based on that article. So if anyone has not seen the NPR article, it is an interesting read.
Is it on the website?
Yeah, I think it was ProPublica.
Oh, it was ProPublica?
Okay.
Yeah.
Is that on our website or no?
No.
Could you send out a link to that article?
Okay, that'd be great. I'd like to see that.
All right, last action item, I'm going to motion to discuss, amend, and approve a name change to Table 1 AMCT drug box.
Motion.
All right, got a motion? Is there a second? Second. Brian, you're up.
I want to hear.
So, being the kind of particular person that I am, back in, there's kind of a colloquial term to how we carry drugs or agents in the state of Arizona that we refer to as the drug, and we refer to it as the drug box list for many years up until the 2007 work group that we did a big revision on the drug box rules that had not had anything done to them for years and years. And when we made up the list, there were some things that were in people's scope of practice that actually weren't on the drug box list back in those days. And they're not all carried in a drug box. For example, you don't carry 13 feet of oxygen in your drug box. It may be stashed somewhere else. Large bag IV solutions frequently may be in a trauma kit, or they may be in a cabinet on an ambulance, or things like that. And so we changed the name to get away from that kind of term, that all of these things are in this box. And in fact, today with the changes that were made to the medical direction and base hospital rules, the only thing that's required to be actually in a box is technically controlled substances, which have to be in a hard-shelled case that's difficult to reach without a power cutting tool. And so this drug box, this term got re-added back onto this table when we moved from it being in the rules to it being outside the rules, and somewhere in there it just got changed back. So I had proposed that we change that. It used to be much longer. I was asked to shorten it up from what it was called before. And this fits in with the names of the other tables for the what we call the interfacility drug, or the interfacility transport list, and so on. So I would like it to be changed to agents authorized to be administered by EMCT classification and minimum supply requirements.
That was the old title, right?
It was much longer than that.
Okay.
Originally, it was much longer than that, and I was asked to try to shorten that up a little bit, and that's where I shortened it back up to, rather than the concept that all of this stuff is in. Pardon? Say it again, Smiley. Agents authorized to be administered by EMCT classification and minimum supply requirements.
And that's shorter?
Oh, that's way shorter than what it was from 2008. I have it here. It used to be called eligibility for authorization to administer, monitor, and assist in patient self-administration of agents by EMCT classification, administration requirements, and minimum supply requirements for agents.
Oh, I'm impressed. Occam's razor, man.
Well done. Well done, Brad. Thanks for shortening it. Authorized to be administered, what's the proposal?
What my recommendation is that Table 1 would be called agents authorized to be administered by EMCT classification and minimum supply requirements.
Now it seems much shorter after you told us the other one.
Made it more palatable.
So, I'll give you my 2 cents, and that's all it's worth. Simple is better, and all of those words are in the first paragraph of the statement. My medics love saying it's in the drug box list, and we all know what that means. If we change it, they're gonna be like, what?
Well, it was that longer one for over 10 years.
I know, I love the drug box.
I think, I will speak in terms of, simple is good for me. When I try to find something, if it's not easily found and I don't know what the title means, I'm unlikely to look at it. So I think the feedback that if someone should just see a drug table list, they know what they're looking for and using. I definitely appreciate what you're saying, that it may not be a box per se, but I think it kind of is what people use that colloquial term to describe. And even if I think their IV fluids may not be in that drug box, they're typically in another box, which is still a box that's being carried. So.
How about box/container?
How about this?
The reason that this came up in my brain is because I had to have people rewriting policy after July 1st when the new rules went into effect with the controlled substances and everything. And everybody was referring to stuff being in a drug box. Well, a lot of these things aren't necessarily in a drug box. So that's why it
I got you, I understand.
come up in my brain like that. So
I know I still say clicker for the television channel controller, but still do the drug box anyway.
And to be honest, when I can't remember how to, if I don't have my computer with me, I get on Google and put ADHS drug box and it pops up. So now and then I can find a table really quick.
Maybe you have to Google a paragraph.
I know. I'm never going to remember that paragraph.
A short paragraph.
Yeah.
A shorter paragraph.
It depends whether you want to be philosophical or functional. Functionally, it's the drug box. What else is it? So if you want to be philosophical, you can argue yourself out of simplicity. But if you want to be functional, it's the drug box.
So I think we'll take a vote since we're almost out of time. All those in favor of approving changing the name, say aye. All those opposed?
Aye.
All right, the motion does not pass.
they're not. That's okay.
I do appreciate the thought process.
You keep us in check, which is good, Ryan. All right. Any agenda items to be considered for the next meeting?
I want to just use this as an opportunity to let folks know that in the, and I should have brought this to your attention earlier, in the ambulance equipment rule revision process for the ambulance supplies, for the ambulance equipment, one of the changes that's being considered is to allow an agency, I'm going to make certain I say this right, so if I don't say it right the first time, I'm going to come back and re-say it, to only carry those agents from within the approved drug box that the medical director has approved for administration by those EMCTs. So what that means is if you're a medical director that does not allow your staff, because you have a feeling that albuterol sulfate is not a good drug, even though it's an approved and required agent on table, the drug box table, they would not be required to carry it for that service. Right now, technically, every EMS agency is supposed to carry every agent that's required in this drug box. And there's fewer and fewer of them because many of them are now optional. But this is an effort to assist agencies to reduce costs that they will never use. And just it's kind of a regulatory fix for a bad piece of regulation. What seems like a bad piece of regulation. So anyway, that's in the current proposed language for the ambulance equipment rule.
Would that come to MDC for approval or no?
It won't come to MDC for approval. It'll go through the normal rules process where anyone can participate and provide comments. MDC can provide a comment if it wishes, and we'll bring that forward and include it in the process.
Just so I understand, you weren't talking about the required agents, only optional agents.
No, the required agents.
That a medical, if a required agent by the state was on the drug box list, and the medical director said, no, I don't want that required agent on there, then they would be able to make that.
They would not be required to carry it at that agency. That's how the language is.
We need to look at that and make a comment on that one then.
One or two of the agencies at that meeting had said that their medical director didn't provide them authorization to administer a couple of the medications. I can't remember which ones they said, and so they were stocking them, but had no means of ever administering them. And their concern, right? And so their concern was that we're paying for these medications that we can't administer because our medical director won't allow us to.
But isn't that in conflict with?
That's just what they were saying.
The table then. I don't understand. If you have a
But
table.
it's not in conflict with Arizona's schizophrenia about giving the local EMS medical director, which basically requires your breathing and you have a license in the state of Arizona, functionally. Oh, and you have a couple of, and you took ACLS, which kills people, and so forth. This is really important, that functionally full authority to ignore regional protocols and guidelines, even state functionally. There's so much authority vested in the individual medical director that functionally, if I were an agency, how in the world would I say, I don't care if you don't like epi, we don't want to pay for epi, we know it turns to keto in the heat, and all that kind of stuff anyway, so I'm not going to let you give epi. Feel free to buy it, but you're not going to give it. I don't think there's any statutory or regulatory authority at any level to tell that medical director, you can't say that. I mean, there's a lot of right there. There's really vast authority given to the local medical director.
But
they can't change the drug box, but they can say you can't give that drug.
Right. No. I get that. So somebody doesn't want it in the drug box because it's a required agent. It seems like this commission for many years now, I don't think there's been a drug in the last 15 years that's been added to the list that's not been optional. I don't think there's one drug on there that, all the drugs that are on there that are required have been required for many years. And they stay on the drug box list. Although we've made some optional, there's been nothing added to the list for at least 15 years, I'm sure, that was a required drug. They were all optional anyway. So Mike, and I think you and I actually had a discussion one point in time about the concept of just making them all optional and leaving it up to the medical director. But it would seem like you should do that then if you're going to give them the option of, not carrying it when it's required on the table, then just make them all optional.
This is just a comment that we have received multiple times. We're required to consider them during the rule writing process.
But have you put that into the proposed rules right now, that way?
That language was shared at the last rule meeting.
So the argument for it would be functionally right now, an agency can be forced to buy a potentially expensive drug that they cannot give because their medical director says, I'm not going to allow you to give it. There's no question that medical director has that authority and the agency still has to buy the drug, even though they can't give it. There's no question, and that's, to me, not fair to agencies. So the argument against this would be, the typical agency that goes to the typical medical director knows almost nothing about the rules and regs. And so if they say, hey, we're supposed to carry epi, the typical medical director wouldn't know enough to say, well, I don't like epi and I have the authority to tell you not to carry epi. So the argument against this change would be, if this group sets, help the director set the required versus optional, most medical directors read required as required. Even though there's no question if they wanted to, they can functionally remove it, even though they can't remove it from the drug box.
And I mean, we have done, I think, over the years, we have taken stakeholder feedback to decrease quantities to a minimum supply for a life-saving intervention for patient safety. So I think from a patient safety standpoint, we've done every time a group has come and said, glucagon is a perfect example. We've pulled data on glucagon use. We said that gives an option of getting something on board if you cannot get IV or IO access. But just from a patient safety standpoint, this is significant possibility for a detrimental outcome. if we start not, the rule process is an opportunity to give input. I think certainly this group and medical directors probably need to give that input if they feel like from a safety mechanism.
I don't think we can take action, but can you take a consensus from the group back to that process? If we gave a consensus in open forum and it was consensus? Or does Gail on our behalf, or can Gail on our behalf go on and give that public information based upon this conversation?
So I'm just going to add one other thing. So how many agencies base like bike teams or wilderness teams? Are they, you know, I mean, I don't want to ask, I don't want anybody to answer, but.
Don't raise your hand.
Don't respond to this, but when our crews go out and they do an inspection for an EMS agency, the anticipation is that every required medication will be there, even if, and so there, it creates this kind of challenging situation for the Bureau that we can live with. I got no problem living with it, where we know we're going to get a negative result when we do an inspection. So that does exist.
And when the feedback I usually get is the ones who are going on wildland fires, and they say, yes, we take our bag, but in all reality, that bag sits at base camp, and they take a small fanny pack with what they'll actually carry.
And that's what tactical medics are doing all the time anyway.
This is happening, whether or not they recognize it.
So I think we are over time, so in the interest of people's time and the fact that open meeting laws, I think we do have to end on time as well. Do you have anything we needed to?
I just, Brian's comment about 13 feet of oxygen tubing, it says 13 cubic feet.
No, 13 cubic feet of oxygen, the bottle. That's not in a drug box. That's not in a drug box.
Okay.
Nobody puts that in their drug box with everything else we're trying to cram in there.
I apologize. On the topic that Terry brought up,
Yeah.
what's our consensus?
We've already pared things down to a minimum and in a very reasonable, responsible fashion. That's my suggestion.
And does anyone in the committee disagree with that? That feedback? All right. Call to the public. All right, summary of current events are attached. Next meeting is on the schedule, May 21st. Can I get a motion to adjourn?
Motion.
All right, meeting adjourned. Thank you, everyone.